I welcome Dr. Ronnie George for the keynote address. Dr. Ronnie George is the Director of Glaucoma Services at Shankara Netralaya, Chennai. Welcome, sir.
Thank you, Dr. Roshni, for the kind invitation to speak here. So I'm going to be talking to you about a bunch of glaucomas. And among the phacomatoses, I'll speak a little bit about Sturge-Weber and neurofibromatosis. So your Posner-Schlossman syndrome is actually fairly rare, usually unilateral, and typically comes with episodic high IOPs. You may have mild inflammation during those episodes, and the symptoms are usually blurred vision, pain, and colored halos. But sometimes patients are quite asymptomatic except for the blurred vision. And if you look carefully, you might occasionally see a few coin-like KPs there, or you will sometimes just see the endothelial mark of previous KP. They also sometimes come to you with corneal edema like this, and that's a sign of other underlying issues as well. So this is usually, you see them 20 to 50, it's commoner in males and women. The etiology was supposed to be unknown, but in the recent past, people have been suspecting more and more that a lot of these patients have a viral etiology. And when you actually look at the AC tap done in Posner-Schlossman, you find that for the CMV positive eyes, a substantial proportion actually are CMV positive. So almost 50% are CMV positive when you do a AC tap. And among the patients who are CMV positive, they are more likely to have a more severe form of glaucoma. While traditionally it was thought that you don't actually get glaucomatous damage in Posner-Schlossman, that's not really true, because when you get multiple attacks, you can end up with damage. So you need to do a PCR with an AC tap to rule out an infectious etiology. And the reason why you need to figure out whether there's a viral etiology to it is because whenever you have a viral etiology, your outcomes are a little worse. So when you look at patients who have a viral etiology, generally the high IOP spike is much higher, the maximum IOP is much higher. They're much more likely to convert to glaucomatous damage. So if you identify them, you can actually, and this is individual patients, you can see that most of them had higher IOPs than the patients who had non-viral etiology. So in terms of control, also medical control is a little easier in viral, provided you start the antivirals, and surgery rates are similar in both. So the management is three-pronged. Traditional management of steroids and cycloplegics will take care of it most of the time. Antivirals will help if you have a viral etiology, and when the pressures are raised, you may need to add medications and surgeries. So for me, when I suspect a Posner-Schlossman, what I typically start off with is I start off with the steroid. And I may add a anti-glaucoma medication depending on the pressure. If the pressures are just 30, 32, I might just start on the steroid and call them back in a week or two, see what happens. But one thing that you have to watch out for in these patients is you can actually land up with really high pressures. They sometimes come with 40 and 50, in which case you have to cover them with some other glaucoma medications too. When they come with recurrent attacks which are not very severe, you can even use a soft steroid instead of prednisolone to try and get the inflammation under control. When you're talking in terms of viral infections, then basically you're looking at CMV. So the drug of choice there is valganciclovir 900 milligrams per day for 2 weeks. Then you can reduce to 450 milligrams per day as a maintenance dose. Keep in mind that sometimes these patients have to be continued on the medication for years also. In terms of medical management, you can probably use almost every drug except the prostaglandins and pilocarpine because of the underlying suspicion of viral or inflammatory issues. Laser trabeculoplasty is generally not advisable because the primary source of is trabeculitis, and when you're going to go and tickle up the trabecular meshwork again with SLT, it's really not helpful. And so, so this is one patient who we've been following up for years actually, as Posner-Schlossman, each of these episodes, and this is about some years back. And finally, when we did the cataract surgery, we did a tap, turned up with CMV retinitis, and we started him on medication, and following that, after 1 year of medication, he never has had a recurrence. So if you're doing a surgical intervention in these patients, it's worthwhile to actually do a tap at that point in time. And surgery is basically similar to everything else, except that you tend to tie them down tight, just like with any other uveitic glaucoma, and you tend to be a little bit more aggressive on the steroid because these are hot eyes. Now, Grant syndrome is again very rare, and it's primarily an inflammatory glaucoma. There is a sort of overlap with Posner, Schlossman, and Grant, but the difference is that in a Grant syndrome, you will actually see KPs on the endothelium, on the angle. You may not see very much other inflammation, but you will see these KPs. And treatment is very similar to what you do with Posner, Schlossman, because you treat them with topical steroids and anti-glaucoma medications, and they usually respond very well. So this is difficult to see here. It's very, very difficult to photograph a KP in the angle because it's transparent or translucent. So if I can see it a little bit here, if you can actually look at this little bump there, that is actually a KP in the angle. But what you will normally see is this. You will see these pigmented KPs. So this is somebody who's had a few attacks. There are few KPs here which are transparent, but these pigmented old KPs on the endothelium is what you will see on gonioscopy. And this is usually fairly confirmatory of some sort of angle issues. We'll move to the eye syndrome. And so eye syndrome basically has three components. You have corneal alterations, angle alterations, and iris alterations. And you have typical features on the endothelium. And one of the things with eyes is you have to have a high index of suspicion. I have at least seen 10 patients who are being treated as uveitic glaucoma or as primary uveitis because they think those high PAs are because of inflammation. But you take a close look and you realize it is actually eyes, and the patients can be off the steroid and everything else, and you just need to take care of the glaucoma because it can present in various ways. So your angle alterations are typical. You see these high PAs, and sometimes they're so high that you can actually see the ciliary body very clearly. And this is basically because there's a cellular membrane extending over the endothelium which is pulling the iris anteriorly and closing the angle. And you can get, so this is the iris nevus Chandler syndrome and essential iris atrophy are the three components of it. You can get it in any combination of these. So it's actually a fairly, it has fairly different presentations. And again, this is one more condition where of late viral etiology is suspected to be contributory. In terms of management, you can use any glaucoma medication. SLT is not really a great idea because it's an angle closure. You're really not going to have much of help. TRAB and AGV are the two things that we look at. There's really no role for minimally invasive surgery here. There are a few caveats when it comes to whether you're going to do a TRAB or whether you're going to do an AGV, and we'll just look at a few cases for that. Very, very important to do the gonioscopy before you decide on a surgical procedure, because where the synechiae are will make a lot of differences in your surgical decisions. So this is actually an unusual patient. So if you look at that, you can see a little endothelial changes. You can see PAS here. It doesn't photograph very well, but actually there are synechiae all around like that. And this is the left eye of the same patient. That is not a PI, that is an iris hole. And you can see some ectropion over there. This is what the disc looks like in the left eye, fairly tortuous vessels. This is what the field looks like in the left eye. And so this, what I just showed you, is a very, very rare bilateral presentation of eyes. Both eyes endothelial changes were low. It's a very rare presentation, but you can keep in mind that it can occur sometimes. Now, this patient, basically again an iris hole, you can see the altered iris pattern, you can see the distorted pupil, and you can see PAS here also. So this is what gonioscopy looks like on this patient. So there is all closed, but this bit is open. So this bit actually is open, and this patient, when we finally did surgery, we actually did a TRAB localizing it to this area, because you have an opportunity here. It's not that this TRAB is going to work forever. Over a few years, this is also likely to close, but then you have actually managed to make use of an opportunity at that time. Very often you are left with no opportunity but to stick in a tube, because sometimes this is what the iris is going to look like, completely atrophic, and patient has had cataract surgery before. You can see that the endothelial changes have started to cause a corneal decompensation, and you're left with no options for a tube. The better location for this tube is in the sulcus rather than in the anterior chamber. Coming to Sturge-Weber syndrome, so this is the typical skin subcutaneous hemangioma that you will see. with Sturge-Weber syndrome, I don't know whether you can make out, but you can also get a conjunctival blush, which you can see in this patient, that little redness inside the conch. So it has a fairly high incidence of glaucoma, and basically it's this, you can see all these signs: dilatation of vessels, and that will come to a little later. You can see blood in Schlemm's canal. This is not my image, but because blood in Schlemm's canal is a little difficult to document, by the time you take them there, you don't always see it. The absence of blood in Schlemm's canal does not necessarily mean that there's no increased epithelial venous pressure. You can see hemangiomas on the fundus, and you need to be careful about that. So when you see this in children, they behave very, very similarly to any primary congenital glaucoma. When they're seen in adults, you do get trabecular meshwork changes similar to what is seen in open-angle glaucoma. But most of the issues are because of the raised epithelial venous pressure, which cause issues with outflow. And this is a small series of patients within our hospital, and you can see how most of them present. You see almost 50%, in fact more of them present with 3/60 vision or less, because it's very often unilateral and they don't realize, especially in younger children, you don't realize it. You can get, most commonly it is unilateral, but you rarely can get bilateral eyes when you have very, very large hemangiomas. You do have associations with meningeal hemangiomas, you do have patients with facial and upper lid is common, but keep in mind that these patients can have leptomeningeal meningiomas, and before you plan them for any surgical intervention, it's important that they have neuroimaging. And look at the intraocular pressures at which they present. So a good proportion of them present with very high IOPs, more than 30, 40 or 50, and that's something that is common. And gonioscopy, most of them will have open angles. You will see blood in Schlemm's canal in about 50%, but not in everybody. And like I said, many of them come with very significant biaquate scotomas. And on ultrasound, 5 eyes showed choroidal thickening. So management for most of these eyes, we actually did. So if it's a child, most of the time what we tend to do is we tend to do a trabeculotomy, because you don't want to do a trabeculectomy because of the risk of choroidal hemorrhage, of choroidal effusions. So most of the time, since it's unilateral, you already have a slightly enlarged eye, you probably amblyopic, you try and be as conservative as possible, do a trabeculotomy with a pre-placed sclerotomy. You can do a trab plus MMC if you are really, if the pressures are really high, or you can do an glaucoma volvulus. That's the way that we do it. So we tend to put in choroidal sort of sclerostomy for everybody, but even with that, out of these eyes, about 20 eyes, we had 7 eyes with either a serous RD or choroidal effusion post-op, and 1 late onset RD, which is probably not really related directly to the surgical intervention. So basically we just do a prophylactic sclerotomy. It's very easy to do, we just place it. And what I want you to see is here, this leash of vessels that you can see next to that leash of vessels that you can see next to at the edge of the conjunctiva. That network of vessels is a very, very typical feature of raised epithelial venous pressure. But not showing up. Yeah, okay. So this one. So it's very, very typical of Sturge-Weber. So if you are doing surgery on any eye and you see this picture when you're doing your cautery, then ask yourself whether you have missed a raised epithelial venous pressure, because that's very, very typical. Anyway, the other option that you have is you can actually use oral propranolol 2 mg per kg. Thank you. In 2 divided doses for at least a week before glaucoma surgery, which is continued for 6 to 8 weeks after glaucoma surgery. Sushmita from PGI is very strongly believes in this. So this is an option, but keep in mind that it's a beta blocker, and in children you need to be aware of the issues associated with it. So, but even with this, you look at the number of effusions that were there. There are a significant number of patients who had effusions. Even this 1, 2, 3 patients out of the 15 had effusions. So you can't rule it out completely. So Sturge Weber with glaucoma, like I said, medical management is the first step. After that, goniotomy with prophylactic sclerotomy in children and AG with prophylactic sclerostomy in adults. I will never forget, I will never forget one patient who had ADHD, about 7 or 8 years, very bad ADHD, very difficult to control. IOPs were quite high. So I decided I'd do a trab. So I did a trab, I put in 2 sclerotomies placed. I had no problem on table, tied it down tight. Post-operative kid is very difficult to examine, but he was doing okay. Then he came at 10 days, massive swelling. He could not open the eye, his mother is panicking, everybody is panicking, I am panicking. And because it is looking, you don't know whether it's an infection, whatever. So anyway, managed to get the kid down, catch him, stick a speculum somehow into the eye because you could not open the lid. When you put the speculum in, you can see a massive chemosis all around with the cornea right there sunken down in between. AC is formed. What has happened is he's had a delayed effusion because we leave those sclerotomies unsutured. The whole of the effusion has come out. He just required steroids for about a week or 10 days and he settled down. But this is one of the reasons why you have to be really, really careful in these children. You have to do the sclerotomy because when it's bad, it can be really bad. And that kid finally recovered completely without any issues. So there are a couple of slides on this, and this is basically glaucoma and neurofibromatosis. And here what happens is the ciliary body may show thickening, and there may be, this can be because of infiltration by a neurofibroma. You can also get ectropia and UVA, and this is supposed to be secondary to the endothelialization of the iris leading to tractional forces, resulting in ectropia and UVA. So this is the first case that you see over here, and it's subtle, but all you are seeing is this ectropia and UVA on one side. There's nothing much else. But when you do the gonioscopy, you can see that, that the angle is actually closed on one side in one patient and open in the other. Okay, so basically that ectropia and UVA and the angle closure are what is responsible for the glaucoma in this patient. So in the case 2, you can see this bilateral ectropion. And this patient, you can see the leash nodules. The leash nodules are those little hypopigmented, are seen better in this picture. And you can see the ectropion there too. So there's a wide range of, these cases are treated just like any other case. You treat them medically. Because of the angle closure, you may need to consider surgical intervention, but it's not a pupillary block glaucoma, so they don't really require a YAG PI. So the secondary glaucomas have a wide range of presentation, and you have to be aware of them because most of them have disease-specific interventions. Thank you once again for the kind invitation.
Thank you, Dr. Ronnie. That was very informative, and thank you for sharing your experience with the difficult cases also.